Everyone, and welcome to this evening's Lymphoma Australia session. Tonight the topic is Lymphoma Australia and the AYA patient population, which some of you are. I'm Erica, the National Nurse Manager at Lymphoma, and I'll be the host for this evening. I'd like to begin by acknowledging the traditional owners of the land. I would like to pay my respects to elders past, present and emerging. I'll start with some quick housekeeping as well. So if you've got any questions throughout the webinar, put them in the Q&A function down the bottom of your screen. We'll have a small amount of time at the end as well too to answer some of these questions. So make sure that if you've got questions that pop up when you're going through and when you're listening to all these presentations, just pop them in straight away and we'll get to them as well. There's also a chat function down the bottom of the screen as well too. Now, we won't be monitoring the chat function, so just make sure that you do use that Q&A function properly. If you miss any of this tonight, any of the content that you've got more questions on or would like to listen to again, we'll send it out to you via YouTube and a Spotify link within the next couple of days as well too, so don't worry about that. Something else that I wanted to mention as well too, so we've been building our webinars plan throughout the year, and we've actually got quite a lot of content coming up that really might be interesting for a lot of you in the audience as well tonight too. So following on from this session, we've actually got another session on social and welfare considerations and helping you navigate the healthcare system. We've also got another session on long-term follow-up and surveillance for younger people who are diagnosed with lymphoma. So again, a different topic that you might find really relevant for you. If you do have something really that you'd like us to give you more information on, or something that you can't find any information on, please just reach out to us. We're happy to try and facilitate a session that's really specific. If you've got that informational need there and can't find any of the content, we're definitely happy to help in that space. The other thing I did want to mention as well too, we actually have a support group as well too coming up online on the 1st of June at 6 p.m. And it's for under 40s. So anyone who's keen to find anyone else who's been diagnosed with lymphoma, it's probably a really good session to come along to and to meet any other people. So it's on our events calendar on the homepage of our website, and I can pop it in the chat to this session so you can. So we'll get started then. So tonight's session is presented by Dr. Orly Lavee. Orly is a specialist haematologist with interests in both malignant and non-malignant haematology. Orly sees patients in clinics at the King Cancer Centre in Sydney. She also has satellite clinics in Wagga Wagga, as well as patients admitted to St Vincent's private hospital as well. She's a conjoint lecturer at the University of New South Wales and is a member of the Everkey Haematology Reference Committee. She's completed a fellowship recently in paediatric haematology at Sydney Children's Hospital, fostering an interest in adolescent and young adult haematology. Thanks so much for joining us tonight, Orly.
Thank you for having me, and I also must apologise for our original slot. I had some serious technology problems, so I apologise to anyone that set aside some time that was wasted. We'll try and make up for it tonight. So thank you for the introduction, Erica, and it's lovely to be able to talk to you this evening about this topic. As Erica said, my background is that I'm an adult haematologist, but I have done a fellowship in paediatric haematology to try and really hone into this emerging knowledge area of adolescent and young adult haematology, which traditionally has sort of been lost in the middle somehow. But as we'll discuss in this talk, is a really important area of haematology where we're able to make some real gains in the future, and things are moving reasonably quickly, which is really great. So this talk is not designed to be a completely didactic talk. I'd love to be able to answer questions at the end that you might have. I'm used to obviously presenting academically to other doctors. So if there is something that I haven't covered or haven't explained well, please feel free to let me know. I won't be offended. Obviously, though, I do spend a lot of time talking to patients, so I do get a bit of a feel for what is important to people, but you can help me fill in the gaps. So first of all, in terms of definitions, lymphoma is a really big umbrella term for a whole set of diseases. And I try to explain it that, when you get a diagnosis of lymphoma, you think of the Hodgkin's types and the non-Hodgkin's types, and of each of those subsets, there are lots of different divisions in between them. So it's very difficult to speak about a whole topic and prognosis without going into specifics. And so I won't really be going into the details of the medicine or the lymphoma or the specific treatments that are used, more so sort of broad brushstrokes about the principles of treatment and management in a more holistic sort of a way. So the way we define the category of AYA, or adolescent and young adult, differs according to what country you're in. And that's important really when you're reading studies, because some countries will refer to a certain age group as being AYA, and it doesn't include, the outliers, the older end of the spectrum or the younger end of the spectrum. But in Australia, the definition is between 12 and 25 years. In most of the data, however, it's the American definition between 15 and 39 years at the time of diagnosis. And really the crux of why this area of hematology has become something that we're learning and growing with at the moment is because it's been recognized that obviously people who are in this age group have very unique areas of need that inform how we should and do treat them when they're diagnosed with any cancer, but with lymphoma. So, when a diagnosis comes, early in life, it very much interrupts the plan that you have for life, and there will inevitably be a million things going on, lots of things that are planned, and a lot of things to consider that are very specific to the area of AYA medicine. I've got a few of them here, and we'll go into some of them in more detail, but they're things like, firstly and foremostly, life goals. Are you going to be able to achieve those goals? Is this going to interrupt vital steps in attaining those goals, particularly pertaining to school and work? How do you talk to school and work when this happens? Will they be supportive? Do you fall behind? I guess next most common in terms of concern is fertility. And this is a time in life where people are either planning fertility or assuming that they're going to be able to have a family when they feel the time is appropriate, and all of a sudden this is potentially at threat. Exercise is another one. Young people want to be fit and active, and it's very much a part of your social life and your routine, and that may not be possible during the time that you're having treatment. Financial concerns. In Australia, obviously, we have Medicare covering most upfront treatments that are required for lymphoma, but it doesn't necessarily account for other costs, ancillary costs, taking time off work, and that can be a real worry for people and also their families. Sexual health, and I guess I mean that aside from fertility, and we'll go into a little bit of detail a bit later in the talk. Diet and nutrition, particularly when you want to eat out, when you want to eat with other people, and whether there are any constraints on that. What's safe and what's going to be appropriate during treatment. Psychological health. This is an enormous burden on people to have to carry this diagnosis once it's been made. And the AYA group obviously have very unique needs and need to be able to access appropriate support for their psychological health. And then finally, not always appropriate, thankfully, but sometimes palliative issues, which are very specific to the AYA population, and very confronting themes there, which I won't go into too much detail about, but certainly need to be considered sometimes. So I guess, why do we feel that this group of people is different? There have actually been a number of studies which have demonstrated that there is a higher level of distress when patients are diagnosed with a lymphoma when they fall within this age group. And that's really because of some of the reasons that we elucidated earlier. So this is a time where people are establishing independence, they're completing their education or starting a career, they're finding a partner, they're building relationships. They're not necessarily, they don't have a nest egg that they can draw on. So they're establishing financial stability, and they're potentially becoming a parent or already have young children. So when all of those things are threatened by a diagnosis, the level of distress in people has been documented to be higher. So, people are at a unique stage in their emotional, cognitive, and social development, and the cancer really disrupts that. And also, in addition to that, it can be the first time that you're confronted with mortality. So it's a very confronting thing. Some people may have never even, had a relative who was unwell or have ever been to a funeral. And so it's the first time that people are sort of confronted with this life or death situation, which is extremely distressing. It's a time where people want more intimacy with their peers and independence from their parents, particularly in the younger spectrum of that age group. And they want to feel like they're in control. And sometimes, it makes them feel like they're taking a step backwards in terms of their independence. And they feel quite vulnerable, and they can feel isolated and uncertain. It's a time when people are developing their sexual identity, and it can affect how attractive a person feels, which is really important when you're establishing relationships. And it just stops you from being able to effectively make future plans. So people describe this feeling of being in limbo. So this is a graph from the National Cancer Institute, which is an American body. And really the reason for putting this up is to show you the incidence of cancer according to age. So certainly cancer diagnoses are very much skewed towards the older end of the population. And if you look at the age group that I was talking about, it really does make up a small number overall. However, about 40% of people will have a diagnosis of cancer in their lifetime. I guess why this graph is important is because it really is a good representation of what an adult hospital looks like in terms of numbers. So if you can imagine being diagnosed and having to be an inpatient in an adult hospital where the bulk of the people are up in this age group above 50, really, you can see why you might feel isolated and lost, and that the system isn't necessarily designed for you, because you certainly are a little bit of an anomaly in some departments. And in some departments, we'll have a lot of young patients, but overall, the hospital is an older population. And while cancer in Australia, in young Australians overall is rare, it does have a substantial social and economic impact on individuals, on families, and in communities together. So this is just to illustrate the point that the AYA population really falls in this chasm between the paediatric hospital and the adult hospital, or paediatric medicine and adult medicine. And I think in the past, people have very much gotten lost in this grey zone. The way the hospital system is structured is such that patients who are under 18 are generally admitted to a paediatric hospital, and vice versa, above 18 admitted to an adult hospital. And paediatric doctors and adult doctors don't really often have a forum to get together and talk about issues that may cross over. increasingly we are doing that because we've realized that there is an actual survival benefit in being able to provide patients with more tailored care, but there is a danger that people get lost in between those two systems without a proper handover. I guess another tricky part is if you start as a pediatric patient, your treatment may span a greater time interval, and you may have to transition to an adult hospital, which is also very difficult to confronting, particularly if you've developed relationships with a pediatric institution. They have a very certain way of doing things, and all of a sudden there's a lot more expectation on you to have autonomy for your own, medical issues, because the adult hospital are more used to treating adult patients. So between 2014 and 2018, there were about 5,300 new cases of cancer diagnosed in people between the age of 15 and 24. So that's an average of just under 3 cases per day. And in 2021, according to the data, cancer accounted for just over 7% of all deaths in people between the ages of 15 to 24. And it was the 10th leading cause in disease burden in young people. So Hodgkin's lymphoma, which I'll talk a little bit about later on, was the most common cancer diagnosed in that age group. And bone cancers and central nervous system cancers were the leading causes of mortality in that group of people. So between that period of time, between 2014 and 2018, Hodgkin's was the most commonly diagnosed cancer in people aged between 15 and 24. What I was talking about a little bit earlier is that pediatric and adult hematology have different approaches, or can have different approaches to treating exactly the same conditions. And there's a few different reasons for that. The biology of the disease is sometimes very different between kids and adults. And therefore, treatment protocols have to be designed to mirror that. And young people, kids, can often tolerate much more intense regimens than adults, which is a bit counterintuitive. You assume that an 8-year-old is going to be a bit more vulnerable to treatment than a 40-year-old, for example, and actually the opposite is true. So kids can actually tolerate very, very aggressive chemotherapy and regenerate their cells very effectively. But because of those differences, the clinical trials in those groups has really diverged. And clinical trials is really how we as clinicians get information about what best practice is. So things are trialed in populations in a safe way, and the data is extracted, and that's what informs us and how we develop our strategies. So because the pediatric strategies and the adult strategies are separate in trials, it's very difficult to bring them together in clinical practice. The lymphomas in the AYA population tend to be the more aggressive lymphomas. So the few that I've picked out there that are the most common would be the Hodgkin's lymphoma, particularly a subtype called nodular sclerosing. There's also the primary mediastinal B-cell lymphomas. And Burkitt's lymphoma, which is also an aggressive lymphoma. So the fact that they're aggressive means that they're fast growing, which means we need to do something about them very quickly. But the corollary of that is also that they tend to respond very well to therapy. So we treat them with a view of getting them into remission. And there's a reasonably good chance of doing that. But the regimens need to be quite intense. As I said, there are inherent differences in the tumour biology, which are now only being understood. And by that, I mean that there are certain mutations or switches or mistakes that happen in the cell replication that are very, very unique to a particular age group sometimes. And those mutations can sometimes tell us what the prognosis is. They sometimes help us with targeted therapies. But we know that kids can differ significantly from adults, and young people can differ significantly from older adults. When we look at the studies that sort of predate the definition of this AYA group, outcomes of this group have traditionally been poorer compared to pediatric or older adult counterparts. And it's thought that this might reflect the fact that we're treating young adults more like adults than kids, or assuming they can't tolerate really intensive chemotherapy. And that we're sort of moving away from that now and offering young adult patients regimens that are more similar to kids' regimens than to older adult regimens. And we've also got a lot more choices in terms of targeted therapies that we're able to use. So that data set is actually changing. So this is just a little graph, a little pie chart that gives you a picture demonstration of the types of tumors or the types of lymphomas in the AYA group in the pie chart above, compared to the older adult group in the pie chart below. So really, as an adult hematologist, if I'm talking about what I see the most of, it very much mirrors what you can see down there. So half of that pie chart, the blue, the orange, and the grey at the bottom, is my bread and butter. It's things that are myelomas and CLL and follicular lymphoma. And the more aggressive lymphomas are probably the minority, but in the younger patients, the converse is true, and the Hodgkin's lymphoma, as we said earlier, is the most common malignancy that I see in younger people, with the other aggressive lymphomas also featuring. So then the big obvious questions, which I'm not sure we necessarily have a black or white answer for yet, but we're getting there. So this is really what we're asking, is at what point should a pediatric patient become an adult patient with respect to receiving curative therapy for their aggressive lymphoma? And there isn't, a number necessarily, but there certainly is now more data to suggest, as I said, that we mirror more pediatric style protocols in patients in this group. Also, how do we identify which young adult patients would benefit from more intensive therapies? Some people at the age of 40 already have, accumulated a few other medical problems, and so it puts them at higher risk. So they're probably not the sort of person that you want to offer those intensive therapies to. And also, are there pediatric patients that could have safely de-escalated therapy so that we reduce their risk of long-term effects? So I guess they're competing interests in a way, in that we want to get rid of it. We want to make sure it's not coming back. But we know that if we're treating to cure, then that patient has a long life ahead of them, and we don't want that life peppered with lots of complications relating to their initial therapy. So it's a real balancing act. So we'll talk just a little bit about the types of lymphoma that we see. As I said, I'm not going to go into detail about this, but primary mediastinal B-cell lymphoma is particularly important because its incidence completely covers the spectrum of this age group, and almost all cases of this disease are found in the AYA age group. Biologically, when we think about its molecular signature, it's quite similar to some forms of Hodgkin's lymphoma, and sometimes under the microscope it can trick you and look like some kinds of Hodgkin's lymphoma. But it's a type of what we call diffuse large B-cell lymphoma with particular switches that have gone wrong. And the most common way for it to present is with symptoms relating to a mass in the chest. So the mediastinum is the front of what usually happens in the front of the chest. And so people can come in with shortness of breath, or sometimes a tickly cough or chest heaviness. And the treatment is generally with intensive inpatient chemotherapy. So patients will come into hospital for a period of time, and that will cycle through a number of cycles until the treatment is finished. The second type that I just want to mention briefly is Burkitt's lymphoma. So again, this is an aggressive kind of lymphoma, and about half of the diagnoses of Burkitt's lymphoma are in people at less than 40. The switch that has gone haywire in this particular disease is something called c-Myc, which some of you may have heard of. And so that's the marker that we look for in genetic studies and in biopsies that tells us that this switch has gone wrong. And when I say genetic studies, just to clarify, I don't mean inherited genetic studies. So these mistakes are spontaneous genetic mutations. They're not things that are handed down from families generally. So it progresses very rapidly. But again, when treated with intensive chemotherapy, the cure rate is around 90%. And then finally, the last group that I wanted to talk about briefly was Hodgkin's lymphoma, of which there are a number of different subtypes, the most common being the nodular sclerosing subtype. And again, this would typically present in a young, previously well person with symptoms relating to a mass in the neck or the chest. So the shortness of breath, the cough, the palpitations, or sometimes people just feel a lump. And that lump is firm and it's not sore and it's not associated with a sore throat or an infection and it doesn't go away. You may hear people talking about B symptoms, and that refers to a spectrum of problems. One is night sweats, and this isn't clamminess, but it's drenching night sweats where you have to get up and change your pajamas or the sheets. Fever for reasons beyond infection, and significant weight loss. Patients with Hodgkin's lymphoma also commonly present with an itch without rash, and that can sometimes predate the diagnosis of Hodgkin's lymphoma by a couple of years. So sometimes it can be very tricky. So in terms of the management of these patients who present with Hodgkin's lymphoma, so depending on their age, patients will present or be referred to either a pediatric or adult hematology service. And the overall outcomes are generally good compared to other hematological malignancies. You know, people will always ask you when you've given them a diagnosis, is this the good one? So generally speaking, this is the good one in young people, less so in older people. And the studies, there's a lot of studies on Hodgkin's lymphoma, and because the cure rate is so good, we've honed our attention really to look at studies which allow us to stratify people, so to reduce the possible toxicity. So can we safely not give 6 cycles and only give 4? Can we safely not give radiotherapy so that we don't increase the risk of breast cancer down the track, that sort of thing? So it's really reducing intensive therapies without compromising survival. And as I said, reducing adjuvant radiotherapy wherever possible. And future AYA therapies are likely, I think, to start using more targeted therapies up front to further reduce toxicity. So when I'm talking about targeted therapies, the conventional chemotherapy agents are the ones that have been used for years and years, and they're what we call cytotoxic, which means cell killing. Targeted therapies are generally newer agents where we've worked out the problem that's causing the tumor, and we specifically target that genetic problem in a very clever way. Clever scientists have helped us to do that, and the reason that's good is because instead of being a blunt instrument that just kills lots of innocent bystander cells, they will often just target the problematic cells, and so you get much less in the way of side effects. At the moment, the PBS does not reimburse a lot of these agents up front, but they're available to people who have relapsed because they're quite expensive. But I suspect that if the data supports the fact that they are, very effective in these people and they cause less long-term side effects, then hopefully in the future we'll be able to access them earlier in people's treatment journeys. So there are at any given time, current trials recruiting across the spectrum of AYA age groups. So in various settings, in the upfront and in the relapse setting. So I'll just talk a little bit now about, things that can happen to people. This may not apply to you at all. You may identify with some of these issues. So patients may need to, and I'm talking about, I guess, young adult patients who have already left home and established their own life. It's very confronting and feels like an enormous step backwards sometimes for people who need to move back home and become much more dependent than you ever wanted to be again. Living with your parents is very difficult at the best of times, but can be really tricky if all of a sudden you're back in the child role when you've graduated from that role. You may need help or support with decision making, and legally this can be quite complex, particularly for people who are sort of straddling, late teenage years, 19-year-olds, 20-year-olds, where parents are still very much involved. And sometimes the patient wants the parent to be involved, but legally they can't make the decision as a proxy unless that's been specifically nominated for various reasons. So that can become complex. Often, if people fall ill at this time and they need to take time off from study, for example, it can be quite difficult going back. You lose your momentum, you feel like you're falling behind, and sometimes it's possible to continue those studies throughout treatment and sometimes it's not. So that's a particular problem for people in the AYA group as well. I think overall, particularly since COVID has taught us that we need to be more flexible with people's work and study options. I think it is a little easier now for people to be able to study online, work online, and employers are generally reasonably understanding of those situations. I don't think anybody really had an appreciation for what immunosuppression was prior to COVID, but when it became very well known that people who are immunosuppressed were at high risk of COVID, it was a very acceptable thing to say that you're high risk, and therefore it was grounds to be able to work or study from home. At times it's necessary for us to liaise directly with schools or unis or work, and I think I speak for myself only, but and all the people I work for, I think we're all very happy to do that because we all see how important that is. And again, with that kind of documentation, establishments are generally very understanding, and we're always very happy to be able to provide that. So always ask. If someone becomes unwell at this time, they'll often have very little in the way of accrued sick leave. And so that's a real financial strain. It can be a financial strain on the whole family and can be a source of enormous stress. So we'll talk a little bit now about fertility and sexual health. So I'll talk about them somewhat separately, even though they're obviously married together. The effect on both fertility and sexual health is very much dependent on the type of treatment that you require, and to an extent, the type of lymphoma that you have. If you have required surgery in the pelvis or in any area that is close to reproductive organs, that can be quite a major effect, particularly the ovaries or the uterus. That would be quite rare, I would say, in terms of lymphoma, but for other malignancies, not so much. Radiation therapy can certainly affect fertility, but where possible, we would try not to give radiation therapy to any gonadal organs or organs that are very susceptible. Chemotherapy is there. I guess there's a lot to say there, because there are some regimens which are have much less impact on fertility than others. So it very much depends on the recipe required. And at the time of a diagnosis, this should be a really early discussion. And that should be documented and explored. And I actually would always refer young people, whether they say they want to pursue fertility treatment or not, to have a conversation with a fertility specialist. And sometimes there's actually not much that can be done, but to not have the conversation, I find, is worse. So I guess the sort of situation I'm talking about is more so with leukemias, for example, where people present very, very unwell, and there simply isn't time to do fertility preservation. Sometimes in that setting, I think it's important to just at least talk about the issues and make sure there's a platform for people to be able to ask questions and answer questions and talk about the future, even if really there are very few options at that moment. Immunotherapy, I guess, is usually not a threat to fertility as such, but is often given together with chemotherapy. Hormone therapy we don't generally use in lymphoma. This is more for other malignancies. Targeted therapies, again, less effect on fertility. And then finally, stem cell therapy. So there are a subset of people with lymphoma that who have relapsed after their initial treatment who may be considered for a stem cell therapy. And stem cell therapies are generally quite unkind to fertility, and so there are options for preservation prior to that. So how the cancer affects the fertility depends on a number of things. Importantly, the age of exposure, and I guess everybody in the AYA age group is young, but if you're, for example, if you're a woman, your ovarian reserve is less at the older end of the age spectrum. And I guess that's what I mean by fertility reserve prior to therapy. And to an extent, that also includes men. Biological sex. So, there are some treatments that that women can be more vulnerable to than men, for example. And as per the last slide, the type of exposure. And also cancer-specific effects. So some people who have been unwell for some time, biologically, they've already got effects on their fertility just by virtue of being unwell. They may have stopped having periods or have hormonal interference if they've got a brain lymphoma, for example, or a thyroid lymphoma. So there are certain situations where the cancer itself can affect fertility. So this is just a diagram to illustrate how ovarian reserve is affected by age alone. So as you may know, you're born with all of your eggs as a woman, and at birth you have about 1.5 million of them. And by puberty, you've already shrunk that population down to about 300,000. And by the age of 30, 180,000, and 40, you've got about 45,000. And the sperm quality kind of mirrors that, that pattern over time as well. So that's without introducing any other insults. So this just shows, I guess, graphically, what can happen when you introduce cancer treatment anywhere along that age spectrum. So you've got age along the bottom, and you've got the number of follicles going along the vertical axis. So the ovaries are not able to produce mature eggs in some instances. So that's ovarian failure, and that can be temporary or it can be permanent. So ovaries can be damaged by both chemotherapy or radiotherapy, and you can lose some of the eggs or the oocytes. As I said, the hormonal signaling between the brain and the ovaries can be disrupted, or there can be damage to the uterus or the fallopian tubes. Sometimes if there has been surgery in the abdomen or the pelvis, you can get damage as a result of scarring as well. And that can cause difficulty with the sperm and the egg meeting prior to fertilization, and that can impair sort of natural conception later down the track. So I just wanted to make a little table, which is by no means comprehensive, but which contains some common types of treatments, so that I can illustrate to you the lower risk exposures versus the higher risk exposures. So I guess just focusing on the higher risk one, I'll start from the bottom actually. So TBI is total body irradiation, and that's a treatment that's used as a conditioning treatment for a stem cell transplant. So that really, I guess, pertains to just stem cell transplant patients. Anyone who needs radiation to the brain, and again, that really is just for what we call CNS lymphoma or central nervous system lymphoma, that would be a high risk to fertility. BIACOP is a chemotherapy regimen that we use for people who are higher risk Hodgkin's disease. And we reserve that for higher risk because we know that it has higher toxicity. We obviously use it if we feel that we need to, but in people who have what we call early disease or favorable disease, we try and use another recipe you'll see on the low risk side called ABVD. And that's a decision that's based purely on the staging of the disease, the type of disease, and certain other factors like disease bulk, how big it is, the areas that it's affecting, for example, and some blood markers. So they're the things that we're thinking about when we're thinking, do we need to expose this patient to a more toxic regimen, or can we preserve fertility and reduce the risk of side effects by using a lower risk regimen? Anthracyclines and cytarabine and alkylating agents are sort of collective names for some of the chemotherapy agents that we use, particularly for high-grade lymphomas. And you'll see there in the middle group is intermediate risk exposure would be abdominal and pelvic radiation, which again, we wouldn't do unless absolutely necessary. So, as I mentioned, the most important step in any journey of fertility preservation or discussion is the conversation and the consultation about this particular patient's fertility risks, their goals, their priorities, and therefore how would they like to go about fertility preservation. So there are a few different ways to do it, and it depends on where you are in life and what sort of person you are, and what your approach is. There is the wait and see approach, and that's when patients just usually older patients, I suppose, they want to complete their lymphoma treatment. They don't want to undergo fertility preservation. And sometimes they feel that it would unnecessarily delay their treatment. That's a real anxiety that people have. And I think that's really very valid. And it may not be a priority in their life. Similarly, they may have been given the advice that their exposure is quite low risk. So they're quite happy to wait and see what happens. There is embryo freezing. So that's when a patient's eggs are collected and fertilized with a sperm to create an embryo. And that embryo is frozen until treatment is completed or the patient is ready to carry a child. And that can be with the use of their partner's sperm or a donor sperm. It depends, where they're at in terms of their relationship. In egg freezing, it's just the eggs that are collected and frozen until the treatment is completed. And then once they're ready to undergo that journey, then they will fertilize the egg and use IVF to become pregnant. And then there's another mechanism called ovarian suppression, which is the commencement of medication to temporarily shut down the ovaries to stop cycling, and it prevents the patient's body from making eggs or estrogen, and that's usually with the use of an intramuscular implantation or a tablet or a nasal spray. And we'll often do that, particularly in a transplant setting. There are the common fertility options available. I think I've complicated this. Sorry. This is just a diagram to illustrate the same point that I made about ovarian reserve, but with respect to male fertility. So both the motility and the volume of ejaculate reduces with a patient's age. So the diagram on the left shows you a normal sperm count. It's obviously a numerical thing, and it's contrasted with a low sperm count there. The things that the andrologists will look at under the microscope are the morphology or the shape of the sperm. So you can see if there are some significant abnormalities in the way the sperm looks, and the motility, or how well the sperm moves. So how well they can swim forward, essentially. So the fertility options available to biological males before treatment are really if they provide a sample for banking, and in some circumstances, if that's not feasible, then they may be able to undergo a minor surgery to take a small amount for the purposes of preservation. So there are a lot of barriers, or traditionally have been a lot of barriers to successfully addressing this topic with patients and successfully implementing fertility preservation stratagems, I guess. And I've just got a few of them here. So the first one, we've talked about that fertility preservation may delay treatment and therefore lead to poorer outcomes. And in some circumstances that may be true. I think in the setting of lymphoma, it's probably less acute than an acute leukemia, but certainly there are circumstances where people present with very advanced disease who are very unwell, who need intervention very, very soon. And so there isn't time. Some people are simply unaware of their fertility options, or it hasn't been discussed with them. And I think we're getting better at that as a group. Sometimes people are not in the headspace at all. I mean, you've just been told that you've got this horrible diagnosis. It's the last thing you're thinking about. If you're really, really young, it's not something you've ever thought about. And it's really hard to have that conversation when, you know, you're terrified and you're not taking anything in yet and you're just in survival mode. The other important thing, I guess, to emphasize is that we need to tell patients that fertility preservation, unfortunately, does not always necessarily translate into successful fertility. I mean, we get lovely stories filtering through about patients that we knew, 10 years ago who have just had a child, and it's heartwarming and lovely, but there are a lot of years of trying or pain, and it can be a really grueling process, and sometimes patients aren't able to regain fertility or carry a child, and they sometimes take up other options. Not a routine part of treatment discussions. Again, I think we're getting better with that, but there are certainly times where it hasn't been discussed adequately, and I'd encourage all of you to have those conversations if you haven't already. And also lack of knowledge, skills and resources available. And I think this is particularly true for patients who are from regional or remote areas where fertility preservation can't be done just around the corner. They'd have to travel to a major centre, and it may not be straightforward logistically, and there may not be good relationships between those units to be able to easily do it. So I mentioned before that when we talk about sexual health, it's not just about fertility. and not just about sexual function as such. So having a cancer diagnosis and going through chemotherapy brings up all sorts of issues, values, body image, the social and cultural expectations are all very relevant. And it can place a great strain on relationships. I mean, libidos change, your desire to have sex changes completely. The person that you're with may feel like that they're hurting you, or there are all sorts of situations that can come up and can be affected by having treatment. Erectile dysfunction, I guess, is another one that is very, very common in people during treatment, and the fear that that is irreversible, which most of the time it is not, but it can be very, very stressful, and it's something that the patient often thinks, well, it's, I can't really talk to anyone about it because they're bigger fish to fry, but it really has an enormous impact on people's emotional well-being. So there's a study from 2012 that showed that more than half of AYA survivors report dissatisfaction with their sexual function, which is a really alarming number. And I think this is not necessarily just because of the mechanics. I think it's important to note that cancer is a trauma, and so it can really affect you for a long time. And I'd encourage you to seek help early. And moreover, around the same number report the ongoing issues 2 years after treatment. So this is sort of something that people will carry with them for a long time in some cases. So what sort of problems can occur? People can get pain during intercourse because of reduced lubrication, or if they've had abdominal surgery, or if they've lost weight or gained weight, it can be quite difficult. Body image concerns because of hair loss or hair growth, skin changes, general appearance from steroids, those sorts of things, reduced libido, psychological distress, arousal difficulties, and erectile dysfunction. So I just wanted to talk for a second about clinical trials, because as I mentioned, this is the way that we get better at doing what we do. And we generally like people to be enrolled on clinical trials because it's a way of giving people early and affordable access to emerging therapies that otherwise would not be accessible. We are continuing to try to build bridges between adult and pediatric institutions so that we can get more AYA-specific trials, so that we can bring in all of those unique medical and psychosocial needs, and to understand how the toxicities are also very unique in this group and how to address them. The trials are also aimed at looking at the biology or the vulnerabilities of the tumour itself, so that we can pave the way for those targeted therapies and less toxic therapies. I guess one thing that has been difficult, particularly in patients with Hodgkin's disease, is that we use tests that try and sequence the genes of the cells. And in Hodgkin's, which is the most common malignancy, the most common lymphoma in young people, when you look at under the microscope, the actual Hodgkin's cells, it's not a sheet of abnormal cells. They're these bad guys that are buried in an immune response. So it's actually like looking for a needle in the haystack to try and get those genes to find out where the problem is arising. Just a little scientific aside. So I heard Erica mention that you have got a talk coming up about this, so I won't go into a huge amount of detail, but survivorship is a really important topic, particularly in young people, because we're hoping that period of survivorship lasts a very long time. For cancer survivors overall who have been diagnosed as an adolescent or young adult, the risk of developing a second primary cancer on average is about 2 times as high for the general population, and it does vary from cancer to cancer. But of those subsequent cancers, in a particular study, about 20% were in people who have been diagnosed with Hodgkin's lymphoma between the age of 15 to 24. And I think that very much reflects, I guess, treatments of a yesteryear where we hadn't yet learnt how to de-escalate therapy in people that didn't necessarily need more aggressive therapy, but it's very sobering. So as I said, cancer is a trauma. It's carried lifelong. And along with that, I think on some level in everyone, in varying degrees, there is a lifelong fear of relapse or recurrence, sometimes just lurking in the back of people's minds, sometimes very much in the forefront of people's minds, and it can pose a real problem, and it's very difficult. Late effects and long-term follow-up clinics are designed to recognise and screen for the survivorship issues along this journey. And I guess one of the most important things about that is age-appropriate cancer screening. So things like skin checks, breast checks, pap smears, colonoscopies, gastroscopies, prostate screening, that sort of thing that happens as you get older anyway, but perhaps with a little more vigilance in patients who have had chemotherapy because they are more vulnerable. And some people feel that it's actually, in attending those clinics or those follow-up appointments with your regular hematologist or oncologist, that it's quite empowering to understand what your risk is. So it's a known quantity, and then I guess it gives you license to be able to take action or, be vigilant, prevent and recognize problems. But it can also be distressing, particularly since it's, you feel as though you've been robbed of the right, I guess, to be carefree for that period of time. And the rumination on that can cause ongoing stress. So I'm almost at the end of my prepared slides, but I just wanted to draw your attention to this body of work, which has been put out very recently, which is, I guess, just an interesting data set and recognition of the fact that this is a specific group that we are interested in improving outcomes for. So is the cancer in adolescents and young adults in Australia in 2023. So it's now and it's here, and it's been put out by the Australian Government, Australian Institute of Health and Welfare, and you can easily find this publication on the internet for free and download it. And it's not, I guess, a holistic sort of a piece. It's more about summaries of data and a broad brushstroke view of what's been happening with us for the last few years. So I'll just finish this part by summarising my key messages. I guess you're not alone. It can feel very isolating, but there are a lot of support networks that exist, and we're continuing to make more effective and less toxic treatments, and we're trying very hard to do that. That AYA patients have unique medical and psychosocial needs. I would urge everyone to take advantage of all the resources available, and all the people who are around to try and access all of those things. I know it can be very overwhelming when you enter a system like this, but you do get used to it. And also that the management of AYA lymphoma is a very multidisciplinary practice. We as a team at St. Vincent's, we have medical staff, nursing staff, dietitians, physios, occupational therapists. We have clinical psychologists and exercise physiologists. There are all sorts of people involved who are all integral parts. And so we never make any of these decisions in a vacuum, and nor is any patient treated in a vacuum without any of these ingredients. And then finally, I'll bang on again, we need better collaboration between adult and paediatric hematologists. and more AYA specific trials. So with that, I'm happy to take any questions that you might have and hope that I can answer them. Erica, would you mind facilitating that part?
Yeah, absolutely. I also have questions that I was madly writing down. So I think one of the questions that come through for you, Orly, someone popped in the chat when I think perhaps you had the slide up about talking about the different high risk categories and different medications that constituted high risk and low risk. And Brendan would like to know, is dacarbazine the same risk as procarbazine?
Yeah, because it belongs to the same family, I would say it is reasonably similar. The caveat being that dose is also important. So, you know, there are some very dose intense regimens, there are some less dose intense regimens, and the number of cycles. So we also work on cumulative dose. So there are, I guess, levels which we've worked out are more toxic in various situations according to cumulative dose, and that goes for all sorts of side effects, cardiac toxicity, for example, so effects on the heart. You know, there is a certain cumulative dose that you can safely have before you have those side effects.
Okay. One of the, I don't know if it's necessarily a question as much, but I was looking at your key messages and your take homes that you want to everyone to take home as well too. And something that really has stuck with me throughout my nursing career, looking after patients, particularly in this cohort, was that cancer has such a huge impact on your body image as well too. But one of the things that you really, and it's one of the hardest things you can do in this space as well too, is to communicate. Talk to your loved ones about your concerns as well too, and speak to the people in your circle. And if you feel like you can't, or you need to bounce your ideas off someone, lymphoma nurses are the perfect go-to. There's nothing that we're afraid of talking about. We also have very little filters as well, so nothing is off limits. We are happy to talk about everything as well too. So if you've got questions and you're not sure if something is normal, there's people who can help you and who can bounce these ideas off you and help you navigate the path going forwards as well too. So I think that's really important as well. Here we go, we've got another question that's come through. Regarding targeted therapy, would this be relevant or an option for someone with some sort of recurrent T-cell lymphoma?
Yes is the answer. Yes, so T-cell lymphoma I haven't talked very much about because it is reasonably rare. But in the relapse setting, there certainly are both PBS subsidised and I guess compassionate access schemes now for patients who have relapsed T-cell lymphomas. So generally speaking, those regimens have less effect on fertility. I guess some of them, the one that I would speak about is pralatrexate, which is a relative of methotrexate. And that's a medication which you cannot use while you are trying to get pregnant or conceive a child because of the effects it has on cell replication. But oftentimes those things will not be long-lasting effects. So it's just at the time of the medication. And I think that goes for a lot of different medications, not even necessarily chemotherapy medications, that there's probably not much data for in pregnancy. It's very hard to do clinical trials in pregnancy for obvious reasons. People don't want to be a guinea pig. And so I guess you'll find that with all sorts of medications, we err on the side of being very conservative. So a lot of the recommendations when you look at Mother Safe or places like that are really that sometimes they'll say not recommended because we simply don't know, and we can't risk that vacuum, risking people and risking pregnancies. So I hope that answers at least part of the question.
Yeah, no, I think it does. Something that we get asked a lot, actually, and I think there's so much focus on the fertility side of things beforehand, and then the fertility when you actually are going through the process of planning your family as well too. But a question that we often get asked is, should women expect their period to return after treatment, and when should they expect a period to return,
Look, it's
if at
really
all?
variable, really very variable. And I mean, sometimes it's up to a year. So I don't think, I guess that would be something that I would encourage people to speak to their physician about, their treating physician about. But there is a very wide range of normal, and it doesn't necessarily reflect irreversible infertility if that doesn't happen naturally. It also, again, depends on the type of treatment that patient has had, and how many lines of therapy, for example.
Okay. If you guys, more questions coming through as well too. Another question that I had about fertility preservation as well too. So, like you mentioned, in some certain scenarios, people, particularly with higher grade types of lymphoma, don't necessarily have a huge amount of time to allow the fertility preservation process to actually happen. If this was something that was really important to a patient of yours, for instance, what sort of things, is there certain things that you can do to try and patients a little bit of time so that then this does become something that is really viable for them, or at least a considerable option?
We have good relationships with our fertility unit in the Women's Hospital, and together we've developed these sort of unstimulated protocols, if you like. So traditionally, if a woman wants to preserve her eggs, she needs to go through sort of a cycle of IVF or hormonal stimulation in order to facilitate that, to have an egg harvest. But there are rapid protocols that have been developed now that can be done more quickly or in an unstimulated way. And it's not as effective, but sometimes you get something rather than nothing. And sometimes that's enough. So there's certainly those sorts of things. Things like ovarian wedge resections are appropriate in certain circumstances. In leukemias, we tend not to do them because we cannot separate leukemia cells from the ovary. And so there is a risk of reimplanting leukemic cells, less so with lymphoma. Leukemia is more of a liquid tumour than a lumpy, bumpy tumour. But there are ways that can be done. And there are obviously also other options, which I didn't talk about, like adoption and surrogacy. But, those things, I guess, are beyond the scope of this talk.
Okay. One of the questions that has come through is perhaps a little bit tricky, but you might be able to answer it. So you mentioned that patients participating in clinical. My son was on a clinical study called the Urinet PHL Cycle 2 in 2018. His treatment was, oh goodness, DECOPDAC. Are you aware of any results released pertaining to this clinical trial? It might be a little bit hard to answer.
Sorry, I'm not sure about that one. Yeah, I'm sorry, I wouldn't be able to speak to that effectively.
That's all right. Brendan, if you wanted to reach out to us at nurse@lymphoma.org.au, I can see if we can find something to try and help answer the question for you if you did want something specific in relation to it as well. If you guys have got any more questions, pop them through. Otherwise, I think we'll start to wrap up as well too. This talk will be available afterwards as well too. We'll send it out to everyone so that if there's something that you've missed, you can catch up on it. But I'd just like to say thank you very much, Orly, for taking the time to do this with us tonight. I really appreciate it. And I think that these sort of opportunities to talk and to raise these issues that people commonly are affected by in the AYA patient population are really important, because a lot of these things unfortunately go unsaid, and the more that we talk about them, the more that we raise these issues as well too, the more people feel comfortable asking their questions as well too, and getting the support that they need.
Yeah, terrific. Well, thank you for having me.
Thanks so much, and thanks guys for coming along. Have a good Monday night.
Good night.